Hi, my name is Wichowski, and I'm going to discuss with you my quality improvement project of fall prevention and the need to change. Currently, falls are the most frequently reported incidences in adult inpatient units. Between 700,000 to 1 million patients suffer a fall each year. Between that, 30 to 51% result in injury from minor injuries such as bruises to severe injuries such as broken bones. 79% of falls occur in patient rooms. Falls are associated with increased length of stay, increased discharge rates to nursing homes. In 2008, Medicare and Medicaid have stopped reimbursing hospitals for costs and care associated with falls, causing the hospital to absorb those extra costs. An average cost of a serious fall is an average of $13,000 and an increased stay of around 6 days. As our population ages, there is a greater risk for falls. Joint Commission showed some of the primary causes of inpatient falls involved inadequate staff communication, incomplete orientation and training, incomplete assessment and reassessment, environmental issues, and delayed care provision. Even though many hospitals and units have preventative measures in place such as fall risk assessments, fall bracelets, bed alarms, and so on, there still seems to be an increased rate of falls. Looking at my hospital, SUNY Upstate, there is no difference, and something needs to change.
I constructed a graph demonstrating the amount of falls that occurred each month from April to September 2016. As you can see, the falls peaked at 61 in the month of August, increasing from just 27 in April. These numbers, I feel, are extremely too high. This data was taken from all adult inpatient units at SUNY Upstate. Even though we have preventative measures in place, it is clearly not working, and we need to change.
At my hospital, we use the Hendrick Fall Risk Assessment, which is presented right here, and the delirium screen, which is right here. They are both to be done every 8 hours, and upon admission, the Fall Risk Assessment helps assess patients more at risk for falls, and the delirium screen, when patients are in the hospital for a period of time, the more time spent, the more at risk for delirium they are. With delirium comes the risk for fall. We also have neon orange fall bracelets, door signs, post-fall protocol, socks, and bed alarms. All of these help in identifying patients at fall risk or helping post-fall, but are they all being used properly? And if they are, why does the rate of patient falls continue to be so high? I want to take what we are already using in the hospital and build upon it. I think there are a lot of ways that we can modify how we are preventing falls, and I have a few ideas to show you. After doing research on fall risk prevention, one article, The No Fall Zone by Lola Butcher, showed the participation of 325 hospitals in a fall risk prevention program. Some of the interventions that they used were color-coding the whiteboards, teaching back the call bell, after-fall protocols including a questionnaire, and placing the number of days since a fall occurred in a common area for nurses to see. The end result, there was a 6% reduction rate in falls and an estimated $16 million in savings for the year. So I took this information and kind of revamped how my hospital does our fall risk prevention. What we are going to continue is the Hendrick Fall Risk Assessment and Delirium Screen, fall bracelets, socks, and door signs, along with hourly rounds and making sure they are being done properly. The changes that are going to occur, the post-fall protocol. We are going to keep the protocol but add in post-fall questionnaire, which you can see up here. I want it to help assess the causes of falls and see if there are any trends to help find better ways to prevent these falls. I want to change our whiteboards, putting different information on there, such as if a patient is a 2 assist, they're toileting, if they're on bed rest, if the bed alarm is on, things like that. So if a nurse answers a call bell, they can more easily help them out instead of getting them out of bed when they are unable to and having them fall. I want to make sure the bed and chair alarms are being checked with the oncoming shift along with hourly rounds, and making sure to reteach the patient the use of call bells, especially the confused patients, and placing the number of days since a fall occurred in the break room. Having a visualization of this will help to encourage nurses to continue to prevent falls. I decided that the testing unit would be the neuro ICU and the neuro floor unit, testing 2 different units over a 3-month period. After 3 months collecting the data of falls, discussing concerns and new ideas with the staff members, and then implementing any changes and trialing again for another 3 months. After the total listed, I want to thank everybody for watching my video, and I hope you got something out of fall risk prevention.